So tell me about like how you use anesthesia to your advantage, and specifically, single lung ventilation, and what was the other one?
High frequency jet ventilation.
Yeah, high frequency jet ventilation.
Anesthesiologists are usually always very fascinated to work with me because I start asking them for things that they just like, huh? Why is this guy asking for them? So a little bit of my background is, well, while I'm an interventional radiologist, I actually am a direct pathway graduate, and I'm a board certified internist that did a lot of ICU work in my old days. So like there are things that usually I start asking for that they're like, wow, that's interesting. So say I don't have any of this. Say I'm just like in the average practice. I don't really have access to single lung ventilation, to high frequency jet ventilation. So in that case, I do the basics that actually can be accomplished from those exact techniques. What I would do, I will first tell the anesthesiologist, what's the tidal volume? Typically it's 500, 600. I'm like, no, you don't need it. Just take them to 100% FiO2, and I'll look at the patient, depending on the size of the patient, it may be like 300 to 350 tidal volume. Rarely ever patients need more than 300, 350 tidal volume, cc's, for a procedure that's going to last less than 1 hour. They do just fine. What else do I do? If I have to go for apnea to ablate a lesion during the initial access, which is actually the most critical portion of the procedure, I will ask for the patient to be on apnea for the first 30 seconds or 1 minute of my apnea. Why do I do that? Because the initial portion of the ablation is the portion where you are trying to collapse those alveoli. You are trying to collapse those distal bronchia. Once you collapse them, the risk of pneumothorax, and especially the risk of bronchopleural fistula, is decreased significantly. And then when I'm done with my procedure, then the patient can start to be ventilated. And then when I'm done with my procedure, then I go to what I call my lung seal technique, which actually I presented it in SIR maybe 3 or 4 years ago. The lung seal technique, we can address it later a little bit.
No, let's do it.
Okay.
Tell us.
So basically with our lung seal technique, that's when I discovered that provocative pneumothorax and all these fascinating things that at so much time were probably unnecessary. And honestly, I have never needed to do one. Why? Because it seems that my rate of pneumothorax with lung ablation and transdiaphragmatic ablation for liver lesions was actually lower than my rate of pneumothorax with lung lesions. And we do over 1,000 lung biopsies per year. So we're a very active practice when it comes to lung interventions. So what is this lung seal technique? It helps to see images because it's a little bit interesting, but I'll try to explain it. So let's say you did your ablation, whether it's in the lung, whether it's through liver, going through lung. You try to accomplish against the same thing, which is collapse those alveoli, collapse the distal bronchioles to try to decrease the rate of an air leak. Look, guess what? Don't overburn the lung. That's why I say the smallest power settings. What happens when you overburn the lung? Whether they're in ablation, whether they're in trax ablation, whether they're in ablation or whether they're in trax ablation when you're pulling back your needle. If you overburn the lung, you'll end up with one of the worst complications from lung ablation, which is cavitation. You'll end up with a big cavity, and that cavity will become into a massive bronchopleural fistula, and you'll need some really fun endoscopic interventions by the bronchoscopist to try to get rid of it. Anyway, so what do? You have to pull back your needle, just like you pull it back in the liver. And you start, again, low, 45 watts, maybe even 30 watts for very short bursts. 10 seconds, trax ablations, and pull back 10 seconds per centimeter, 10 seconds per centimeter, until you reach the visceral pleura. I mean, it's very hard to distinguish where the visceral pleura is, so I can tell you, I don't know where the visceral pleura or the parietal pleura is, but basically what I do is I ensure that I stop exactly at the site of exit of the liver. That's where my temperature reaches. My temperature, which is a lot of times pretty easy to see under CT, you could really see where the active zone of the microwave probe ends, and that's where I leave it right at the edge of where I think is the visceral pleura or the visceral lining of that organ. And after that, I ask the anesthesiologist, please, apnea, complete apnea. I pull my needle and I give it time to fill with blood, to fit with, for it to happen. I don't want that patient to breathe. He's already paralyzed. I don't want any air moving in and out. I'm letting that ablated area to collapse, to completely collapse. And usually I leave them like that for 30 seconds to 1 minute as tolerated. And before you do that, you always make sure that the patient was already given 100% FiO2 before you start doing that. That will buy you time before their blood gets deoxygenated. After that 30 seconds to 1 minute, I ask the anesthesiologist, please resume manual ventilation. Why manual? Because most of the time with the ambu bag, all they can give them is 200, 250 cc's of tidal volume. So they're not really getting a lot of positive pressure. And positive pressure, guess what? It's your enemy for pneumothorax. So if they're on 10 or 15 PEEP, you're getting a pneumothorax. You want no more than 5. So with manual, they can't really give them much positive, much PEEP. I keep them like that for like a minute or two. And after that, I said, okay, go back to previous initial settings, and I go scan the patient. My needle, and by the way, my needle was already pulled out. I hope I said that.
Sure. You did. Okay. All right. Well, very nice.